Well, hi, David. Good to see you again.
Bill, nice to see you too.
Yeah, what we're doing now is I'd like to discuss the issue of dealing with excessive SAH with our now that we are often getting the Samsaw cycle, we're actually doing quite a good job of dealing with problems with methylation. For example, if we have a problem converting converting methionine to SAMe, we've got good ways of dealing with that and fixing the cycle. Also, if we have too much homocysteine, in other words, we're in pretty good shape with mastering methylation, except that there's been one nagging problem that's been bothering me for forever, namely, quite a few people, now that we're getting hundreds and hundreds of these SAM cycles, we're seeing a lot of people have extraordinary high SAH. And yeah, we have ways of helping that. We know how to, we can, ways to um, enhance removal of if they got elevated homocysteine, or ways of getting adenosine down. And I remember discussing this with you for the last couple of years. And one reason was you were one of the first people to um, a start using the riboside nicotinamide, and you were one of the few that was beginning to do that. And I remember discussing with you the whole issue of too much SAH. And the last time we talked, you mentioned you were taking a completely different approach, and it was one that I thought was really interesting and really promising. Namely, were looking at ways, not trying to regulate and get the SAH level normalized using the cycle, but looking at the way it's excreted through the kidneys and trying to enhance that. And I understand you've made a lot of progress on this, and I'd like you to maybe explain to me and to the other practitioners watching this, where you are with this and the progress you've made.
Good. Well, thank you. In regards to your question about my interest in SAH disposal, I started looking into that because pretty much, the fact that you referred to zinc deficiency and SAH buildup as toxic overload,
Yep.
it always had me thinking in terms of other factors that are contributing to toxic overload in individuals. And I initially, thought of the liver, but I also, came to appreciate that the kidneys have, they also have a transsulfuration process and they have a filtration process. And when I looked up SAH, removal or a breakdown, I came across an article that actually referred to it as SAH disposal in the kidney. I reference that in my on my website link, but it was pretty surprising because they said up to 40% of the SAH is disposed of by the kidneys, and I came to find that seems to happen because of the metabolites of SAH being homocysteine and adenosine are disposed of in the kidney through filtration. And that process, potentially, I've spent a lot of time, trying to address, alkalination of the body and adjusting the pH with sodium bicarbonate. And in regards to the question of creatine, I've been interested in creatine for muscle integrity and that sort of thing. And it was just by coincidence that I came across creatine and methylation and learned that it was, it makes up, it could be 30 to 50 or even more of the use of the methylation compound. So all of this, had me thinking in terms of both alkalinizing for the purpose of improving the kidney function for filtration, and it had me thinking in terms of the improving of the methylation with the creatine. I have what I've been doing with respect to the sodium and the alkalinity is encouraging patients to add sodium bicarbonate and potassium bicarbonate to their supplement plan. The reason for that is because quite often, most patients that have metabolic issues or have health issues have a high tendency towards acidity. So the the function of the kidneys and the function of the enzymes in the body that are involved in the methylation pathway, it's important to maintain alkalinity. And if all of these health conditions are sort of giving us a higher state of acidosis, and I found quite a few, it could be metabolic, it could be dietary that precedes that, it could be things like anoxia or hypoxia, maybe something like when people get either with obesity or with sleep apnea and or increased biochemical metabolism, they tend to be acidic. And these, I believe it seems to me that with the optimization of function, since I found that SAH is disposed of in the kidneys, if the alkalination of the kidneys enhances that removal or enhances the function of the kidney, which is in that filtration process, then it would make sense to give something like sodium bicarbonate as well as potassium bicarbonate. And then I came to find out that it actually improves these enzymes in the methylation pathway. So optimizing SAH utilization or the function with your recommendations for taking zinc could also facilitate that breakdown of the SAH in those biochemical pathways, in those enzymatic pathways.
Well, what I find really interesting here is that you're essentially pointing out that the SAH can be adjusted and lowered not by making changes in the one carbon cycle itself, and that really the SAH all is generated in the body when you have the SAMe give up its methyl, and that's when you get the SAH. However, it's not 100% consumed by the cycle. Then, in fact, you've got quite a bit of SAH circulating around in the blood, and a lot of the regulation is really the degree to which it's excreted. And so it seems like a great idea to do whatever you can to enhance the excretion rate. If you have for these people, these occasional patients who have sky high, difficult to deal with SAH. So this is
Yeah.
so the first thing you were working on then was the trying to do it perhaps by making the pH different and doing this with sodium carbonate. Is this a problem for people who might have heart disease, who might have to be very careful about the sodium intake?
Well, I understand that sodium bicarbonate does not raise the blood pressure as high or as significantly as does sodium chloride. But I think to be cautious and avoid, hypokalemia or lowering of the potassium, it's probably a good idea to give something like a 2-to-1 ratio of sodium to potassium. That way you can take it both in a bicarbonate form. Maybe the baking soda as a sodium source, and then either potassium carbonate or a combination of sodium and potassium. They often come 1-to-1, but then I would maybe add the extra sodium bicarbonate in the form of baking soda in a beverage or something.
I have another question. Since the question is that since kidney function itself seems to be important, if we encounter a patient who has really high SAH, which of course is still a problem of dealing with that really efficiently, should we check for a family history or maybe his history or her history of kidney problems? Maybe that's one of the first things we should do, because there probably are some people who simply have kidney disease or kidney issues, and for them that might be the only reason why their SAH is elevated. I understand they've done knockout studies where they remove the SAHH enzyme And what do they find? Kidney dysfunction. Uh,
Though,
I'm just, that's just a question. It's something that might be a good idea to
well,
check
yeah,
for these people.
I think that there's probably a significant amount of kidney dysfunction that we don't detect on a standard metabolic panel and test panel. Maybe you could assume people with hypertension or with diabetes automatically have a degree of kidney dysfunction,
Yes.
or people with these inadequate diets, or even acidic conditions where their kidneys aren't able to keep up with detoxifying or alkalinizing these acid compounds.
What I really like is the fact that we have had some difficulty with a lot of patients of getting the SAH down, and you're suggesting that we shouldn't be only trying to do this through the cycle, and I like this approach. Continue.
Yeah. Yeah. And, there are things that you can maybe do to support the liver function or helping in the transsulfuration process. I think a lot of that is addressed with, things like glutathione and N-acetylcysteine and reducing the homocysteine. But I would imagine, given the high degree, our insufficient diets, our toxins exposure, medications that we're exposed to, even the environmental atmospheric pollutants. So many of these things are contributing to acidosis and probably may be one of these sort of unaccounted for conditions that are leading to these chronic disabilities that we have.
So one of the issues then is the ideal pH level for kidney function, and I understand, I believe it's to be slightly alkaline. Maybe you could explain or educate us on that.
Well, it seems like, it takes energy to maintain an alkalinity, and yet, a 7.2 to a 7.4 seems to be the optimal pH but both the enzymes function at, and the kidney filtration activity is the highest.
So there might be some way in difficult cases, maybe it might be worthwhile to even determine what somebody's pH is with a little bit of
Yeah.
testing.
Yeah, they do these different tests. Nephrologists will do the anion gap, or, internists will do, rely on that sort of thing. I think that, a simple home detection test is good. I think that you can do a salivary or a spot urine. Just as a diabetic might do a blood sugar test or something like that, a urine ketones or something. A pH, if we can observe a fluctuation in the pH with supplementation, bringing it up a little bit from where it happens to be, I think that would be a good indication that you're achieving some degree of alkalination.
Yeah, so that right there would be a way to somewhat bring down the SAH.
Yeah.
Okay, have you started doing this? I mean, have you started doing this with patients?
Well, I do. I've recommended it as part of sort of an overall detoxification strategy for patients with the elevated SAH. I've recommended other things like taurine and the vitamin E and the A and the such that helps with the liver, and also things like MSM, which are particularly helpful for the kidneys. But in regards to alkalinity, I'm probably going to improve that, because I've done quite a bit more research since you and I started talking about this last week, and start monitoring patients maybe with a follow-up SAH test, and see if I can get a compliance with both the sodium and potassium bicarbonate as well as the creatine.
Okay, so that's something we need to do. We can start following up on that and see the cause and effect directly on the SAH. Yeah, that
Yeah,
seems promising, and hopefully it'll be a big effect. But we won't know until we
yeah.
do. Have you had the opportunity yet to evaluate possible benefits from this for the individual patients? Um,
I haven't been able to get enough information in follow-up SAH testing and in compliance with that protocol to be able to say with certainty that we're getting that that we're looking for, but I think we could find it if we're able to get, a little bit more vigilant with that.
Well, it certainly sounds like it might help and may possibly help a lot, and it doesn't seem like it will do any harm. So I think we need to, we're going to have to we will learn all of that. We'll find out just by getting experience. This is great. How any other ways of you've been looking at? I know one thing I've learned just looking now at hundreds and hundreds of these people with the really high SAH tend to have high pyrols. They tend to have more severe copper zinc imbalances. They seem to have just higher oxidative assault. And so I think that that ties in with what you're doing.
Yeah, I think that these oxidative states and inflammatory states of all sorts, it could be arthritis, it could be, just a generalized inflammatory condition of any sort. Uh, I think all of those lend themselves to creating this acid environment.
And SAH, elevated SAH, especially if it's considerably elevated, does really nasty things with DNA repair, assault on your DNA, and it even affects neurotransmission. So there's a great tendency of, or greatly desire to normalize SAH, not just for
Yeah,
methylation, but what it does with gene expression. And
yeah, yeah. Um,
you,
I think
excuse me, you,
we see that both in the undermethylators and the overmethylators. You get that elevated SAH.
most of them are undermethylated, but some of them are not, and some of them are normal. You could get elevated SAH even if you don't have a methylation problem. In other words, that
Yeah,
doesn't all come. You can get terribly high SAH even if you're absolutely normal methylation. It can happen to anyone if you're, for example, if you have a problem with excretion.
I think this pathway, which tells us so much about the DNA methylation and the activity of the serotonin and dopamine. Um, it's also very interesting in the complexity with regards to this creatine. And
Yeah.
I think that, you asked me whether or not I thought creatine supplements for over might be, and I kind of that and looked into it a little bit more, and there may actually be a mechanism that's leading to overmethylation because of the need for more creatine,
David,
as well as undermethylation.
I think it would help if you would explain why you began thinking about creatine and creatine supplements as being helpful. Maybe explain the theory behind that. It's very interesting.
So creatine, I started looking at that when I was looking at creatine as a supplement for muscle integrity, and was surprised to find that it played such a big part in the methylation methyl compound utilization. It's a big component of this SAM methyl formation. And the question that I had was, well, certainly if you can supplement with exogenous creatine, then you could leave a lot more SAMe and these methyl compounds in that methylation pathway in order to be utilized for other methylation purposes.
It used to
If
be,
create
excuse me, I believe from the research I've done over the years, it used to be as much as 70% of all of the SAMe utilization and was for creating creatine. And it's come down by a way lately. It seems to be more like 40 to 50% now, and I'm not quite sure why. But the lion's share of the SAMe that's being used is to make creatine. So that makes sense. So if you supply creatine, you ought to be helping directly, not just with having enough SAMe and to do the job, but you also be helping bring down the SAH. Oh,
right,
that's an
right, and
interesting idea.
you're
Any evidence that it actually works? Have you?
Um, well, I don't have any evidence that it actually works. No, I don't. I couldn't say that that I've seen an increase in the SAM or a decrease in the SAH from giving that. Again, it's for me, it's a matter of being assured that there's compliance and that we can do a retest in a certain period of time where a patient can, we can show that their numbers have changed,
So
and maybe even.
theoretically, it should help, and it would be especially useful for people who are undermethylated with the high. Yeah.
Yeah.
So it's
And it may be useful for the overmethylators also, because, if you think about, the fact that creatine is such an important part of the methylation pathway, if there was a higher demand for creatine, it's possible that that methylation pathway could be exaggerated. If the body, for instance, if somebody has Parkinson's or has a autism or has a neurological or a muscular need for more creatine, and yet they're not getting it, it could be that their methylation pathway is kicking up in an attempt to produce creatine. Maybe they've got an issue in arginine or glycine. Maybe they're not forming enough of those precursors for the creatine.
I
But
think
it could be.
it's certainly a possibility. And one question I have is, do you have any idea of how much creatine you have to give to make a real impact in a supplement?
The recommendations for it seems to be for, standard, use of creatine and supporting that methylation function might be, like, 5 to 10 grams a day. I know bodybuilders are taking, upwards of 20 grams a day. So I like to use, a higher dose as a, sort of a macro supplement protocol, but I would say, 10 to 20 grams of creatine per day as part of a health regimen, maybe if for athletes or for people who have this, who are significantly undermethylated. I think that would be a pretty healthy dose. And I'd probably also add arginine and glycine to that protocol as well.
Well, this is all very interesting. Of course, my interest is mainly not athletes getting bigger muscles, but which would be most people would want, but mental health. And the question really is, can creatine really help somebody who is one of their major problems is too much SAH? And it sounds really promising. And I guess this is all in its infancy, and I encourage you to continue doing this. And please let us all know exactly what you've learned, because within a short time, you might have a really slick way of fixing the problem of too much SAH for people where we have difficulty, in many cases have difficulty getting that down, even with everything else we're doing. So I encourage you to keep doing this and let me know and let the group know. You're in the Google group. I think this is a very promising possibility. And I love the idea of trying to do this from just straight excretion without not having to do only the manipulations we've been doing. I think we have helpful ways of bringing it down, but this seems like a really relatively easy, obvious way to do that we've ignored in the past. So thank you very much, David.
Good, good.
Yeah, keep in touch with us, and hopefully you'll have developed something. I suggest you might even want to patent it at some point. But good for you. Thank you very much.
Thank you. Thank you.
Bye.
Take care.
Thank you,
Oh,
Dr.
interesting stuff.
Thank you, Dr. Sickles. I'm just going to get Dr. Walsh up on just a second.